everyone. I'm Erin Kuhn Krieger from Rolfe Pancreatic Cancer Foundation. Thank you so much for joining us for this special Pancreatic Cancer Awareness Month edition of Wellness Wednesday. We're so excited to have you here with us today as we've got incredible presenters talking about such an important topic of better outcomes in pancreatic cancer. It's been an incredible month so far. Just last week, we celebrated Rolfe's 25th anniversary. We had a heartfelt and joyous gala event where more than 300 members of our community got together to honor loved ones, celebrate progress, and we raised $355,000. And donations are still coming in. It's incredible. We're so grateful for everybody who was there, who bid on the silent auction, and have supported us over these last 25 years. These funds will help us to continue to provide free, personalized support for patients and their families, while also advancing early detection research. To learn more about our gala and make a donation, you could click on the link in the chat. And if you look on Facebook, you'll see lots of great pictures from the event. And the thing is that we're not slowing down yet. Before the year ends, we have two exciting opportunities to raise awareness and support Rolfe. First, on Tuesday, December 3rd, our Young Professionals Board is hosting a trivia night at Old Town Poorhouse in Chicago. It's a great way to meet others and support the cause. So check the link in the chat for more details, and you could sign up to get your seat. Second, we're kicking off our annual Matching for a Cure campaign. From now until the end of the year, every donation will be matched dollar for dollar up to $30,000. It's incredible. Click the link in the chat to be able to learn more on that. So today, we're thrilled to explore an important topic, improving early detection and outcomes for pancreatic cancer. We'll learn more about pancreatic cancer early detection, or the PRECEDE Consortium global study, as well as how each of us can participate, whether we have a family history or not. A couple of quick notes before we get started. You could ask questions in the comment section throughout the session or email us at info@rolfefoundation.org. We'll save all the questions to the end to ensure that we have time to address them all. Now, let me introduce our incredible presenters. Christine Drogan is a licensed and board-certified genetic counselor and the Associate Director of the Gastrointestinal Cancer Risk Clinic at University of Chicago. And Dr. Bradford Chong is a medical pancreatologist and serves as the Director of the Pancreas Program at the University of Chicago. Both have impressive expertise and fascinating insights to share with us today. Christine and Dr. Chong, thank you so much for joining us today.
Thank you.
Thank you for inviting us.
We're so happy to be here, and congratulations on your wonderful event. It's really impressive, all the work that you all do, and we're proud to be a part of it.
Thank you.
With that, I will share my screen. We have some slides to share with you, and we'll get this going. Okay, great. Like Erin said, my name is Christine Drogan. I'm a genetic counselor at the University of Chicago, and joined here by my colleague, Dr. Chong, who's our pancreatologist. And we are a part of a study that's called the PRECEDE Consortium, which is really focusing on finding pancreatic cancer as early as possible so that we can have more options for treatment and better outcomes. And so this is a study we have been working on for the last 4 or so years, and are excited to share it with you all. So the PRECEDE study is an international study. I'll show you in a few slides a map of all of the different locations that are participating in this study. And it's multi-institutional, so there's many different hospital systems around the world that are participating. And really, the emphasis of this consortium is on collaboration, because we know that we have a lot more that we need to learn about pancreatic cancer, what increases somebody's chance of pancreatic cancer, how we can identify pancreatic cancer at earlier stages so that we can improve outcomes. So the goal of this consortium really is to all work together so that we can get better at finding cancers early, effectively screen for pancreatic cancers, figure out what somebody's risk of pancreatic cancer is, and hopefully even prevent pancreatic cancer from happening. And the emphasis on this in this study is really on those who have either a family history of pancreatic cancer or who have a gene mutation that may increase their chance of pancreatic cancer. And the goal of the study is a lofty one, but I think it's attainable, which is to increase the 5-year survival rate from pancreatic cancer from 10% to 50% within the next 10 years. So how is this consortium going to reach these goals? I said a lot of it is done with collaboration. So we know that we need to all work together to be able to make an effective difference in this disease. So the study is planning to enroll over 10,000 people with a family history of pancreatic cancer. We'll talk a little bit about the different groups that are included in this study. To join the consortium, the different hospitals and different centers must agree to share information with the consortium so that we can all learn together. Of course, any participant who agrees to be a part of the study will have their information anonymized, so no one knows that it's you that is participating. But all of the information that we learn is available to any participating center so that we can really have the numbers to be able to do research and make conclusions about different data. The study also has formed many subcommittees that have focused on different areas of research. And we'll talk a little bit about what some of those subcommittees are. And this is because people have different expertise who are all coming together, and it's hard for one person to tackle all of these different areas. And so kind of dividing and conquering is one way that we're hoping to do this. We also have partnerships with many other groups, including the National Pancreas Foundation, the John Lewis Foundation, as well as some biotech companies who have early detection products that they are hoping to validate to see, is there a test, like a blood test, for example, that we can use to try to identify pancreatic cancer early. So this consortium really is a way for lots of different people who are working on lots of different areas of pancreatic cancer research to all come together to try to make a meaningful difference. So these are some of the subcommittees that are a part of this study. We want to make sure that we are promoting diversity, equity, and inclusion, because we know that some groups are more likely to be affected by pancreatic cancer than others. And so we want to make sure that anyone who is affected by this disease is able to be a part of the study and is included. Then we also have groups looking into clinical genetics. So are there new technologies that we can use to perform genetic testing in people both with a personal or family history of pancreatic cancer to find out was there some sort of gene or other inherited factor that may increase the chance of pancreatic cancer. We have a group that's focused on modifiable risk factors, studying the influence of maybe tobacco use or BMI on pancreatic cancer risk. There's a lot of evidence on developing better biomarker tests, meaning is there something that we can look for in the blood that may be increasing or decreasing before a person is diagnosed with pancreatic cancer? And what can we be measuring to assess for any changes that could help us find pancreatic cancer at earlier stages? There's a group of really smart radiologists who are invested in developing better imaging techniques, including the use of artificial intelligence to help detect pancreatic cancer at earlier stages. And then we have a really strong team of people who are expert in biostatisticians so that they can help analyze all of this data to make meaningful conclusions. And this is a picture of actually a few meetings ago in 2022. I don't have a picture from our most up-to-date meeting from just a few weeks ago, of all of the different investigators from around the world that all came to New York to meet in the same room and discuss some of these issues that we're all facing around the world. And the group only continues to get bigger and bigger. This is a map of all of the different centers in the US and Canada that are participating in the PRECEDE Consortium. And you can see really representation from many areas of the country, though certainly we know that we have more work to do, especially in the middle of the country, in the Midwest, and trying to increase recruitment from those areas that are not as well represented at the moment. But there are more and more locations that are joining the consortium really on a monthly basis, which is really exciting for us. We also have multiple sites in different countries around the world, some sites in Europe, but as far as Singapore that are participating in this study. And we are so thankful for our international collaborators to be able to participate in this. And we know that this is a global issue, not just something that we're facing in the US. And so having other perspectives is really valuable to us. This is a timeline of the study so far, and it ends in 2023, so we need to update it for 2024. But this is a relatively new consortium. We started in 2019 and really have been able to do quite a bit in the last 5 years. We have enrolled, you'll see, over 7,000 people so far into the study, and are really excited about how much we have grown throughout the last 5 years. And I don't think that we're going to be slowing down anytime soon. This is our enrollment as of November 1st for all the sites that are participating. And you can see the growth is following a really nice curve. Started off slower, but as more and more institutions join the study, our growth has really shot up there. And we're enrolling nearly 200 people a month across the study into the consortium, which is just fantastic to see. So who can join the study? Really, anybody is eligible to participate. And on the back end, the research team has a way of kind of funneling people into different groups. So you do not need to know what cohort you fit into. The team will figure that out for you, but there's a few different groups of people that we are studying. So the main cohort that we're really focusing on at the moment is this cohort 1, and these are the people that we think are at the highest risk of pancreatic cancer. So these are individuals who either have a family history of pancreatic cancer and a gene mutation that may be increasing their chance of pancreatic cancer, or have 2 or more family members who have had pancreatic cancer. These are also the folks that are generally being offered pancreatic cancer surveillance, which, as you may know, is not something that we're routinely doing for the general population at this time. So cohort 1 is really what we're focusing on at the moment, but there are lots of other groups of people that can join the study. So we won't go into details about all of these different groups, but basically anyone with a family history of pancreatic cancer or a gene that increases their chance of pancreatic cancer, like in the BRCA1 or 2 genes, and even people who have pancreatic cancer themselves or who have a pancreatic cyst are eligible to join as well. We also know too that oftentimes people are interested in participating in research that may not fit into one of those other buckets. And so we have this cohort 5, which is kind of like an other category, which are for people that are interested in research and who want to participate and can provide their information for the study as well. So as I mentioned, we're really focusing on cohort 1 at the moment. So these are the people who have either a gene mutation and a family history of pancreatic cancer, or multiple family members with pancreatic cancer. And As I mentioned, at this time, pancreatic cancer screening is not recommended for the general population, but it is recommended for these groups of people that we think are higher risk. And we're focusing on this group primarily because we are able to test out some of these early detection tools in people that we think are more likely to develop pancreatic cancer over the course of their lifetime, with the hopes that what we learn from this high risk population can then eventually be applied to the general population. But really, we need more research. When it comes to cancer screening, unfortunately, pancreatic cancer is behind many other types of cancers like breast cancer and prostate cancer and colon cancer. And we really need to catch up so that we can develop tools that are effective for everybody. And really, why is early detection so important? And why is it the emphasis of this consortium? As many of you may know, unfortunately, most pancreatic cancers are diagnosed at stage 3 or stage 4, when it can be very challenging to treat and surgery may not be an option. And this is because there are really non-specific or vague symptoms that people may have that may not necessarily point directly to a diagnosis of pancreatic cancer immediately. It may take some time before the pancreatic cancer is diagnosed. There was a study that was completed that showed that people who had pancreatic cancer that was detected as a part of a screening program, so this is this purple line here in the middle, they lived much longer than people who had pancreatic cancer diagnosed outside of a screening program. So what this tells us is that early detection of pancreatic cancer through surveillance is effective at finding pancreatic cancers at earlier stages. We just have to get better at figuring out who is at increased risk and need to develop other tools that can identify pancreatic cancer early. So you may be wondering what is involved in participating in this study. To participate, there's a consent form that is signed, that you go through it with one of the study coordinators, where essentially we're asking for permission to view medical records. So if you have some sort of screening for pancreatic cancer, that we can use the results of that imaging test for the study. And of course, this is completely anonymized so that nobody knows this is your information. But we like to be able to track this information over time to see from year to year, are there any changes in any of the findings? We also perform annual blood draws, and this is something that must be done at one of the participating centers due to some limitations that we have in the ability to process these blood samples. But the goal with this is to be able to share blood samples with companies that are trying to develop early detection tests to see, is there anything that we can measure in the blood over time that may be changing, that may be an early signal of pancreatic cancer. And some groups may actually be asked to provide a blood sample every 6 months. And of course, the study team lets you know about that. Being involved in the study, we may actually also send people some questionnaires. So there's some new interest in studying the habits of people from families. So is there a difference in exposures or areas where people are from, or BMI, other things that may increase or decrease the chance of pancreatic cancer. So you may be asked to answer some questionnaires as well. So with that, I'm going to turn things over to Dr. Chong to talk about some of the research that has been done so far through the PRECEDE Consortium, and to talk about some exciting things that are coming up. So Dr. Chung, I'll pass it over to you.
Thanks, Christine. So yeah, for the next remainder of the talk, we'll summarize the new knowledge that's been generated from the consortium, and as Christine mentioned, provide some context on future directions and also latest updates from our past conference a month ago. So to orient the audience, as Christine was describing, we have patients that we generally understand are at higher risk for pancreatic cancer in relation to their family history of pancreatic cancer, known genetic mutations. And so these are the patients that we've enrolled in pancreatic cancer surveillance, which comprises of annual MRI of the pancreas or endoscopic ultrasound, which is a procedure where they use a camera to go down the esophagus to the stomach, and from there using an ultrasound to assess the pancreas and look for small tumors. These are the tools that we're using for pancreatic cancer surveillance, but we identify that there's quite a bit of variability when it comes to actual reporting these findings from surveillance. And so the consortium, they propose standardizing the reporting of these findings and agreeing on a universal terminology when putting these reports together. And really the goals of this was to improve consistency in the reporting findings, enhancing the performance of high quality exams, and providing more reliable and accurate information over time. So out of the consortium, there are two working groups, one for EUS, the endoscopic ultrasound, and one for MRIs. And they were able to generate a standardized document for reporting these findings. In addition to the template, also agreeing on a recommended MRI protocol. So, our hopes is that this will kind of maintain accuracy and consistency of our reports to, ultimately make sure that in terms of early detection, everyone's on the same page in terms of how we're, finding it. Next slide. So, prior pancreatic cancer early detection studies, they've reported this lack of diversity when it comes to race, ethnicity, gender, and really disproportionate to the population that's served. And we already know that pancreatic cancer disparities exist, differences in outcomes, treatment received, based off some of these kind of socioeconomic differences. So it was important for us as a consortium to begin to address these differences to ensure everyone really has the best chance. So we did a study of our own cohort. So cohort 1 is, as Christine mentioned, so the highest kind of risk patients in our consortium, looking at about 1,100 patients. And about 2/3 of them were female, and the vast majority of the patients, almost 90%, were non-Hispanic white. So certainly an underrepresentation of minorities respective to the general population that are not being represented in our consortium. We suspect that these differences are probably related to under-identification of the high-risk individuals and underrepresented communities and under-referral of these patients. We're also seeing that once these folks get into surveillance, that participate in the actual research activities is fairly similar once enrolled. So it's really a call to increase identifying these patients and funneling them in to our surveillance program. So our goals as a consortium over the next 3 years is to decrease the disparities in underrepresented minority enrollment and increase that enrollment by double. Some of the strategies that we're considering right now is kind of exploring and trying to identify perceptions and knowledge about pancreatic cancer surveillance, both at the patient level, but also the physician level, assessing their knowledge about guidelines, genetic testing, as well as access to genetic testing, and then knowledge and screening about family history of pancreatic cancer. This is part of one of the committees that Christine mentioned, the Diversity, Equity, Inclusion Committee that's actively working on kind of strategic approaches to address these disparities and increase uptake of screening services. So, next slide. So Christine shared a really nice timeline, from kind of consortium concept in 2019 to where the study is today, and so we felt it was important to do an interim analysis of the enrollment, and so one aspect of this is we had a lot of imaging data, for all these folks who were in surveillance and and underwent MRIs and endoscopic ultrasounds to get a sense of what are we seeing in terms of abnormalities in the pancreas. And so again, we looked at cohort 1, the highest risk cohort in this group, and kind of broke it down by folks with a family history of pancreatic cancer, folks with genetic mutation for increased risk of pancreatic cancer, and then folks who had both. And some of the things that we found is that about 35% of them had one or more pancreatic cysts, which is kind of one of the kind of precursor lesions that can in some folks progress to cancer in the future. We found that increased age as well as family history of pancreatic cancer were predictive of folks having a pancreatic cyst. And so what these findings would suggest or infer is that family history of pancreatic cancer may underlie risk for pancreas abnormalities that's sort of different and separate from kind of the tumor biology that we see from these genetic mutations. And so it's really a call that that for folks who are at high risk with a family history of pancreatic cancer, it's really important that we assess them for genetics and have a sense of what their genetics mutation status is in order to really parse out what are the biological differences between having a genetic mutation and having the family history of pancreatic cancer. Next slide. So we recently had our annual meeting just a few weeks ago, and one of the exciting things about pancreatic cancer and early detection is there is promise for in addition to endoscopy ultrasound and MRIs is a blood-based test, blood-based biomarkers for early detection, and there are a number of industries and industries partners who are very interested in this and doing research and looking to collaborate with PRECEDE. I just put down a couple examples among a number that shared some of their data at our annual meeting. Immunovia is one company that have been actively developing a blood-based test for early detection of pancreatic cancer, and their top test models are pretty promising, with 85% sensitivity and 98% specificity. There's another industry at our meeting, ClearNote Aventact. They're using sort of a different technology, using cell-free DNA, so changes in the cell-free DNA in the blood that has the potential to detect pancreatic cancer in the early stages, obviously in a more non-invasive way than certainly a procedure. And some of the results are showing a 30% relative increase in the detection of early stage over some of these more traditional blood tests like a CA19-9, which we know has significant limitations when it comes to early detection of pancreatic cancer. there was another company called PacBio that was sharing information about their technology with next generation short read sequencing. So short read sequencing, just to orient, it's basically you have your gene, your DNA, and it's kind of chopped up into tiny bits, and you read that individually. And doing that short read technology, you can kind of generate an extensive analysis of the genome, and really where the power lies that for that is the potential to increase accuracy and sensitivity for non-invasive testing for early detection, like liquid biopsies, and the potential applications of a technology like this would be for earlier detection, improve treatment selection, and improve monitoring for cancer recurrence after it's occurred. Next slide. So just to pose some future directions that we as a field and as well as PRECEDE are looking towards. So I mentioned one of the industries, Immunovia, and the blood-based biomarkers. They're in the active process of clinical validation study, which should be completed by the end of this year. So we're very much looking forward to what the results of that are in the clinical setting with a large cohort of patients, and seeing how that might kind of lead to hopefully downstream kind of prime time use. There are other technologies that are being explored that were shared at the conference, one being advances in molecular imaging. So there's technology that's been used with ultrasound imaging in some other cancers like breast cancer, using microparticles or microbubbles where these they bind to specific targets in biomarkers in cancer lesions. And so I'm thinking about how this can be applied to pancreatic cancer to enhance kind of imaging signals of small lesions in pancreatic cancer. So that was an exciting kind of development that was shared at a conference, and we're looking forward to more rigorous studies applying that. And then a pilot study that the consortium is in the works is to kind of better understand the interactions between other risk factors and these known risk factors that we're talking about with genetics and family history. For example, we know that smoking is an independent risk factor for pancreatic cancer and obesity and excessive alcohol use and some of these other things, but how these interact or how these kind of add kind of cumulatively to the overall risk for a patient who may have a family history. So, this is worth studying and something that we will do because there may be a subgroup of patients where by their genetic mutation specifically or their family pedigree, maybe they don't meet that kind of threshold or criteria for pancreatic cancer surveillance. But if there are other risk factors on top of that, such as smoking, obesity, it would beg the question of is that the kind of patient that their risk becomes such that they should be eligible for pancreatic cancer surveillance. So these are the unknowns that we're aiming to examine in the near future. Next slide. So I think there was a question about how to be part of PRECEDE. Well, this is the website. Encourage you to check out the website. There's a lot of great information on there about kind of the history of the consortium and our research collaborators, resources for patients, caregivers, survivors, and some of the ongoing work. So folks who are interested, this is where you can sign up. And then last slide, Christine. And then any specific questions about what we shared or PRECEDE or pancreatic cancer early detection, these are our emails, and please feel free to reach out. This was our last slide, so I'll pass it back to Erin.
Thank you so much. We have a lot of questions, so I want to jump right in. So our first question says, I might fit the criteria for cohort 1. Both my mother and grandmother died of pancreatic cancer, and I'm over 50 years. I'm interested to learn more and probably join. What would the next steps be?
That's a great question. So for folks who have a family history, what we typically would actually recommend is having an appointment either with us if you're in the Chicago area or someone closer to you. And on the PRECEDE website, you can find a list of all of the different participating centers if you are somewhere outside of the Chicago area. And having an appointment either with myself or one of my colleagues and Dr. Chong, we talk all about, any genetic testing that we would potentially recommend and what their surveillance would be. And as a part of that appointment, we also have you speak with our research coordinator and have you sign up for the study in the clinic.
Great. So the next question, we actually have a lot of questions asking about who pays for the testing. One person said, I hear MRI and I think it's way too expensive for me to join. Are participants responsible for any of the costs related to the testing and being involved in the study?
That's a great question. So not all of the groups are recommended to have surveillance like the MRI or the endoscopic ultrasound. That's really reserved at this time for the folks that are in cohort 1, that highest risk group. The people that meet the criteria for surveillance, that is billed to your insurance. So that is considered standard of care for people that meet the screening criteria. It is billed to your insurance. Any of the blood draws for the study purposes is covered by the study. So that would not be billed to you nor to your insurance.
Okay. Next question is, both my parents had pancreatic cancer, but they obviously are not in the same bloodline. Am I considered someone in group 1, cohort 1?
Yeah, I'll touch on that a little bit, and then Christine, welcome your thoughts too. So this is one of the ones where it doesn't, quite exactly fit that box in terms of what we kind of define as familial pancreatic cancer on like the same side of the family. But this is also like something that we're actively kind of interested in wondering as a field about is if you have parents on different sides, obviously, does that kind of cumulatively increase your risk for pancreatic cancer? I would say as a site, if they're over 50 and have those both parents, we've been talking with them about pancreatic cancer surveillance and it kind of going through the protocol and talking about risk benefits if the patient is agreeable, then we generally have been surveilling them. But Christine, any additional thoughts on that?
No, I think it's kind of a gray zone, right? And I think a lot of what we're doing in pancreatic cancer feels a little bit like a question mark. But we do have people participating who have both parents with pancreatic cancer. And as Dr. Chong said, we have an individualized conversation about pursuing surveillance. And I believe that there is actually a paper in the works from the PRECEDE Consortium that is looking at those individuals who have two family members or two parents, with pancreatic cancer, and what are the outcomes of those individuals, and are they getting screening or not? So hopefully we'll learn more about that over time.
Our next person says, all of this analysis is clearly necessary because of all the variability. However, to what end, near term and long term, can this be used to save or extend lives?
Yeah, that's a tough question. With with pancreatic cancer, we didn't explicitly touch on this, but I think everyone's well aware of how morbid a disease this is. That historically, and even still now, 5-year survival for this disease, it's very low. 13% for 5-year survival. The greatest opportunity that we have, to increase those numbers is early detection. So detect at stage 1. We have good data, right? There's good data out there as well that folks who are diagnosed at stage 1A, the earliest stage, that they can have 5-year survival of up to 80%, even more. So therein lies our greatest opportunity, I think, with this consortium, but then also just early detection in general. Now, the early studies, you have focused mainly on that kind of stage shift piece. I think we need more data in terms of really what is the outcome that ultimately matters in the end, which is survival. But based off of what we understand about the disease and early stage, I think that's our greatest opportunity.
How about the use of AI in making advancements or improvements? Is that something that you're looking into or relying on?
Yeah, there's a lot of excitement in this area as it pertains to AI. I mean, a lot of things that we didn't have the time to talk about today, but there are AI applications in terms of imaging technology. So, there are a number of studies that are using AI and kind of pattern recognition to kind of look back on historical CT scans to see if there are earlier signals. So you may have had a CT scan that reported a normal pancreas, but kind of using the AI technology to look for those subtlest of differences, and then kind of you build that kind of database over time. You collect that data over time, and then the hope is to kind of fine tune that in a way that we can kind of detect these earliest signals on imaging right before a discrete mass shows up. There's other applications of using natural language processing. So actually looking back into the vast world of the electronic health record, right? Looking at things like patient notes, laboratory values, vitals, all this information to see are there any early signals that we can kind of use to kind of funnel patients over to a surveillance program. I mean that would be kind of like a downstream application, right? But these are some of the ways that we're considering this technology that we never had possibilities before. So this is a grim disease, but at the same time there's a lot of promise and there's a lot of movement towards earlier detection.
That's great to hear. How about for folks who have no history of pancreatic cancer in their family? Should they participate? Why is it helpful to get that picture in addition to those who have the history?
Yeah, absolutely. I think it's important for anybody to consider participating. So we're thankful for anyone who wants to. It's about trying to find these subtle differences, like Dr. Chong was talking about. So do people who have a family history or a gene mutation or some other risk factors have some different values compared for whatever these biomarkers are compared to someone who doesn't have any of those risk factors. And so acting as a kind of a control is also very valuable as well.
Great. How about our next question says, if I'm adopted and don't know my history, but I'm Black, should I join this because I'm at a higher risk demographic? And I noticed within the slides it looks like there was a small percentage of Hispanic folks who are participating. I didn't see a mention of Black or Ashkenazi Jews or, like any of those like higher risk folks can you talk a little bit about that?
Yeah, I can talk a little bit, and then Christine, maybe you could touch on like the enrollment piece and things like that. So we know for sure that certain minority populations are at increased risk for developing pancreatic cancer. So the African American population for one, there's a significant risk for pancreatic cancer early detection. I mean, I should also say that they also have some of the worst outcomes that we think are probably related to kind of what happens after the diagnosis. So in terms of treatment receipt, overall survival. Now, is it a matter of not receiving surgery early enough, or not having access to supportive services, or navigating the health system? I think it's probably all of it. And so there's a lot of work that needs to be done there. But in terms of the kind of early detection space, this is precisely why we need the research, right? And why we need to study this prospectively over long periods of time, so we have a better understanding of what are the disparities, not just in pancreatic cancer and who's getting it, but like who's actually getting connected, right, to the early detection and the services that may ultimately improve life, right, and survival. So I hope that answers your question. But Christine, yeah, maybe you could also touch upon just in terms of like the research and enrollment piece.
Yeah, absolutely. Yeah, I think it's tricky when you're adopted and you don't know much of your family history, or maybe aren't even in touch with one side of your family or the other side, right? And this is something that as a genetic counselor, I have people tell me all the time. I take a family history as a part of every appointment to make sure that I am assessing not only the risk of pancreatic cancer, but other cancers as well. And when family history is fragmented, or someone is adopted, or what have you, some of that is also a bit of a question mark for us as well. I certainly would say that if you were interested in participating in the study, that I think that it is completely worthwhile, and we appreciate anyone who wants to give back and move the field forward. Whether or not surveillance would necessarily be recommended, I think in the absence of a family history or a gene mutation, that's not something that we're doing at the moment, but there are still certainly opportunities to participate if you'd like.
Great. Our next questions are about the study in general. So it's a couple parts here. So if you join the study, can you back out? And if you join the study in Chicago and move, can any doctor take the surveillance tests, or do I have to travel back to Chicago?
Yeah, that's a great question. So yes, you can leave the study at any time if you no longer want to be a part of it. You just have to let the study coordinator at your location know, and that is no problem at all. As for moving, that is a good question. So there are many different locations around the country, as you saw on that map, that are participating in the study. And so you are certainly welcome to transfer your care to another location, or even outside of the consortium. What I would suggest is, if you are a part of the study and you're moving somewhere new, just to let them know, I was signed up for this study in Chicago. I know you have it here as well, and so I'd like to be a part of it here too. And that should be no problem at all.
Okay, great. Are there papers from the consortium or research documents that are available to the public to be able to review and see the findings?
Yeah, so that the PRECEDE study kind of website, one of the kind of drop downs is the publications that have come forth, from the consortium. So, some of the studies which I shared today. So yeah, that's readily available, and if there's interest in other kind of primary resources, please reach out to me or Christine. We'd be happy to share that as well.
Yes, I will say a lot of the studies are written up in very technical language that are hard for even me to digest sometimes.
Mhm.
And so also included on the website are various news reports and other articles that have been published on various websites that are much more general population friendly and not as high as high technical language as some of the imaging radiology reports and things like that. So yeah, check
That's
out the website certainly.
okay. Okay, that's great that it's brought down to everybody's level. So somebody logged on late and is asking if the program is currently open to people below age 50 who have one first degree relative who is diagnosed with pancreatic cancer.
Yes. Yep. You can sign up for the study if you're over 18. And on the back end, then the like database kind of figures out what cohort you are in. Typically, if we are to do surveillance because of a family history or because of a gene mutation, that usually starts around age 50, though there are some exceptions to that, but certainly you can be involved in it if you're under age 50.
How about environmental causes? Are you looking into that?
Mhm. This is timely. So our university, we're actually having a cancer disparity symposium today, and like the topic is the environment and environmental exposures. And so what I would say is that yeah, there is some data kind of conferring kind of environmental exposures now, right? Whether that's ambient pollution um, or lead, arsenic. Um, are there kind of signals or are there kind of associations with certain tumors, including pancreatic cancer? There may be, but we need a lot more high quality studies. Certainly in a large patient population, to have a sense of, well, how much is it is it driving the risk? This goes back to what I was saying about the modifiable risk factors, right? So like smoking, diabetes. Um, I mean, we could kind of throw other things in there like the gut microbiome. There's so much that remains to be explored in terms of like how do these things all come together, right, to ultimately inform a person's risk for pancreatic cancer. So I would say as a general statement, probably there probably is some correlation with the environment, but be it uh, with the mechanics of that and to what degree and how should that inform the screening? I think those are the questions that we need to answer as a field.
Do you participate with or collaborate with other pancreatic studies? Or said I thought there's something as well at Northwestern, but I don't see them participating on the PRECEDE list.
Yeah, so I'm not aware that Northwestern is in the PRECEDE Consortium. There are, I think North Shore is joining or in the process of joining as well. But we're excited and clearly open to collaborations as a consortium with all sorts of different groups and patient foundations and with biotech companies, etc. So as a part of PRECEDE is all about collaboration. So certainly invite everyone who is interested in studying this because we know that we have a lot of work to do.
So what about for cohort one? How close do two family members need to be? Siblings, grandparents, parents? How about second family members being the first family member's first cousin? So my mother and my mother's first cousin.
Christine, you want to touch upon that?
Sure, absolutely. So the typical definition of what we're considering a close family member is usually a first or second degree relative. So that would be siblings and parents, as well as aunts and uncles and grandparents. And usually what we're considering doing surveillance for are folks who have, for example, mom and maternal aunt, for example, with pancreatic cancer. But I will say our criteria for who we should consider surveillance in has been expanding over time. And so it's always a good idea to keep in touch with, your doctor or your genetic counselor, if you have one, to figure out, are there any new guidelines? Has this changed? Should this be something that I'm considering?
Okay, and our almost last question is, can you share the percentage of pancreatic cancer that's familial versus environmental?
Oh, I don't know that we know how much is environmental, but we know that about 10% of pancreatic cancers, if we did genetic testing on them, would have a gene that increases their risk. About 10%. There is also a group of people, maybe about 5 to 10%, who have multiple family members with pancreatic cancer. And when we do genetic testing on them, their testing is completely normal. So that's another small subgroup. So most pancreatic cancers are not caused by something hereditary.
Anything to add to that, Dr. Chong?
No, I agree with all that, Christine, and that's what we've seen, with the studies is 20% of these are related to either family history or genetic mutation, and so this is part of the thrust of why this research with early detection and biomarkers matters, because you still have a ton of folks. Well, maybe their parents don't have pancreatic cancer, or maybe at some point they've even gotten genetic testing. So, how do we, achieve early detection for those folks? I think this is where, right, the work that we're doing, and not just us, but really in collaboration with all the other disciplines of, developing, novel tools, that's where I think we're going to make strides.
Are there three key takeaways? We always like to end the session with what are the most important things to get across? Can you share your top three takeaways?
Christine, you want me to,
My takeaway is that we have a lot to do, but there are a lot of people working on this and trying to tackle this problem from all different directions. And so I really feel hopeful about the future of pancreatic cancer. And that's my biggest takeaway as a whole.
just to piggyback off that, yeah, I totally agree. The field is moving very quickly. And despite this being a very challenging disease, I think the field holds promise. Not just in terms of the technologies and the innovation, with some of these blood-based biomarkers, but we're seeing that early detection like is possible, and like the early outcomes are suggesting that folks with screening detected pancreatic cancer, they have better outcomes, they live longer than folks who would be outside screening. Now we need more data. There's no question about it, but that's what the early outcomes are suggesting. So I think there's reason to be hopeful. And then the last part, I totally agree with Christine, is that I think collaboration is the way. This isn't quite like other diseases or even other cancers where a single institution, a single center can kind of figure out these challenges on their own. No, actually, because pancreatic cancer is relatively uncommon to the other cancers, and because it's so difficult to find early on, well, we need multiple centers, right, to come together, right, in the way that PRECEDE is doing, so that we have the most number of patients that we can follow over time and understand how this disease is manifesting, and then combining experts across disciplines. So, we have Christine from genetics and me from pancreatology today, but It's all the other expertise that we've talked about today. Artificial intelligence, data science, basic science, health services. These disciplines are all going to be integral to ultimately ensuring, one, that we can get to early detection, and then two, that we can implement it successfully, and then make sure everybody gets access to it in an equitable way.
Well, thank you so much, Christine, Dr. Chong. Your work is impressive and so needed, and we look forward to continuing to have these conversations and hear the updates and see the progress that you're making. And I would like to thank everyone for joining us today. If you're catching this on the replay, be sure to write replay in the comments and ask questions, and we'll make sure to get back to you. On behalf of everyone at Rolfe Pancreatic Cancer Foundation, we sincerely thank you for your support and send love and light to you as we head into this holiday season and the new year. Thanks again. Until next time, stay healthy and take good care.